Okay.
Okay.
Yes.
Okay, so good afternoon, everyone. This is Winnie again, and welcome to the course. And today I'm going to talk about pharmacological management of pediatric patients with congenital heart defects in the critical care. It is a big topic. There's many medications being used in these patients once they admitted to the cardiac care unit, especially the cardiac critical care unit. It could be pre-op, post-op, and sort of readmission due to complications. So this is more oversight, and then if there's any question. Okay, all right, let's go. Nothing to disclose. Okay. Now my screen has been acting up funny, but I believe you do have my slides, so hopefully you can refer to it. So the outline is really talk about the group of medications we commonly use in pre-op, and then the larger group of post-op cardiac medications that we commonly use in our cardiac patients. And then if we have time, a brief overview of all the potential common medical complications and how do we prevent and treat those complications. So let's talk about pre-op. Now, because of time, and this is an overview, I'm not going to go into multiple primary literature for each drug. It's more to share our experience, over the years with the care of these patients, pre-op and post-op. So obviously when they come into the unit, newborn, and before they can diagnose and figure it out and work up the patients and plan for surgeries, in a lot of cases, they will be coming in from another hospital on L-Prostadil or prostaglandin E1 or Prostin, depends on the countries and the names you give to this medication. They might require diuretics to control the fluids overload and manage as part of the strategy to manage heart failure. And with associated side effects from diuretics, or they might actually require electrolyte supplements such as potassium, calcium, and magnesium. Also, if they end up having some arrhythmias, which we have arrhythmia talk before, they might need potassium, calcium, and magnesium supplements to correct the electrolytes. Digoxin in case of heart failure, function-wise, along with any other indications such as antiarrhythmics, action from digoxin for rate control. And then on occasion, you might see the older patients on heart failure medications for remodeling, such as ACE inhibitors, captopril, and ilanopro. Okay, so those are like some common medications. Now, L-Prostadil, it's actually an infusion, very short half-life, and the mechanism to maintain the patency of ductus arteriosus are displayed here. So I'm not going to belabor the point because lots of content in the next few slides, so you can read about it, and I believe that you would have covered this circulation of the PDA in these newborns, post or newborn pre-op cardiac patients. Okay, the usual PDA closure is actually about 96 hours, although it varies. And permanent destruction of the connection will occur in 2 weeks. So as it closed, sometimes if it was not prenatally diagnosed, these patients might present symptoms once they are home, relatively healthy, then couldn't feed, not gaining weight, and over 2 weeks. And as it closed, hopefully then they seek medical attention, as soon as possible, and they can start the Prostadil to maintain patency until next step could be septostomy, could be planning for surgery. So it is the aim to open it up or maintain it open for the mixing of blood, as disclosed here. But it's very short. It's very short half-life. It's fast onset. So because it's short half-life, you need to maintain an infusion. Now, the rate is as such 0.01 to 0.1. We seldom need to run for 0.1 because of side effects, and also by then, usually with echo diagnosis and the whole team looking after our patients in the CCCU, they might proceed to the next step, such as septostomy, as I said, or planning for surgery. However, we've seen patients on quite a big dose, the 0.1 mics per kilo per minute, when they're transported from another hospital, because they want to make sure that the PDA remains open as they transport, and make sure they stabilize in our unit before weaning it down based on echo and based on sort of stabilization. However, our goal is to titrate down to 0.01 if we can, because we're concerned about apnea, which require extra respiratory support, but also sort of a good dose enough to maintain open until further steps. So it's titrate against the preductal, postductal. Like, I'm not the expert on it, but I'm sure that the course will contain some strategies and targets for management of pre-op cardiac patients. The side effect is what I'm focusing on. You could have fluctuation in blood pressure, especially hypertension, bradycardia, apnea. And if these patients are also happen to be premature, then you might have sort of a apnea spells that's quite concerning and associated with premature age and also dose related. So the faster we titrate down to a suitable level without exposing them to a high dose will hopefully minimize the risk of apnea, fever. And that's hard to tell because, it could be environmental warming, it could be infection, it could be just from a prostatitis fever. So I think that, it's a matter of exclusion, but you definitely want the patient to be comfortable and not overheating because it might worsen the tachycardia or heart stress. It might cause hypocalcemia, hypoglycemia. Again, those lights and labs are monitored closely. And for newborns, they probably will receive a nutritional supplement, TPN, or some dextrose containing solutions and correction of calcium level as needed. Renal dysfunction, although we haven't seen it as much, and also now is very short duration and low dose. Seizure-like activity, again, we haven't seen it because we want to try to use it as short duration as possible, as lower dose as possible. And it might inhibit platelet aggregation. So the sooner we get them off, the better once we plan for next stage for these patients. Okay, now the long-term side effects, I'm not going to belabor the point. A lot of these patients are not on long-term adverse effects. However, in the particular population where you're bridging for or waiting for a neonatal heart transplant, these patients might be on a low dose of prostatitis for a longer time. And that's when you'll see some of the side effects as listed here, such as gastric distension and obstruction. So a lot of these kids are already gastric intolerant. They might require enteral tube feedings. They might not tolerate the feeds well and failure to thrive. So it's already on top of that, the alprostadone might have that side effects. Long-term cortical bone proliferation and digital soft tissue swelling, it does happen. And if they're on it for long, like weeks, and I've seen like occasionally, maybe once every 2 years or so, where they need this long duration, I've seen bone changes on x-ray, and some of them might even cause swelling and pain. So the little one does have a hard time waiting for the heart transplant. Obviously, nowadays you do have other options, so you might not need to remain on a process for such a long time. All right. Okay. Okay, so I focus on our process because the diuretics we'll talk about in our post-op care anyway, and the electrolytes along with antiarrhythmics medications, we already went through that in our previous lecture. So for post-op, what are the goals? Because I think it's important to understand medications, why we're using it. I always think of, from the physiological reasons as well as the medical conditions, that's where then it sort of lead to medication use. So for post-op cardiac patients, the goals are to ensure contractile performance of your heart, blood pressure regulations, be it hypertension and hypotension, that's not a good thing either way. And the parameters and targets might be defined by the patient himself or herself, by the team. So every patient might come up with different parameters and require timely and fine titration with these medications. Rhythm, we talk about antiarrhythmics in case of the rhythm disturbances. Blood clotting, and it could be blood bleeding as well. So coagulation disorder or sort of imbalances post-op after the traumatic experience in EOR with this heart surgery, with going through the blood going through the pump. And then in terms of blood clotting, if you have a narrow stand with turbulence, there might be clotting going on. That might not be a good idea. If they are on ventricular assistance device, definitely anticoagulant is a big player in that post-op care. And blood vessel function in terms of do we have third spacing? Do we have sort of like a capillary leak? What about, in terms of intravascularly, depleted or overall fluid overload? All these common issues post-op require medications to treat them. So let's take a step back before they arrive in the ICU. What happened? Because I think to know what's going on right now after admission, you need to know what happened preceding the admission, i.e., in the OR. So obviously, it's a very traumatic experience with cardiac surgery. It lists a sort of inflammatory response, and the markers listed here. There's extensive contact of blood with artificial surface with the ECMO bypass machine. And of course, the patient's innate stress response, then you have cortisol, vasopressin. However, there's been studies that mention that the cortisol and vasopressin as a hormone internally might be relatively deficient or low when you need them most. So it leads to later on our use of corticosteroids and vasopressin to supplement and boost the blood pressure in these patients post-op. It's very similar to systematic inflammatory response during sepsis. That means the patient is sort of in a very stressed, shocking state that they need a lot of support. I mentioned about capillary leak with third spacing of fluids, and often when you admit these patients post-op, you say that they're sort of fluid logged, and you can't really give furosemide to get rid of fluids initially because the intravascularly they might be depleted, they might be hypotensive, so you don't want to exacerbate with diuretics to sort of drop the blood pressure. So you're sort of in a catch-22 situation where you can't really remove the fluid, but you know that they're third spacing. So they might need some, albumin and other supplements to sort of, top up the intravascular volume. Changes and decrease in kidney function. And that's not exclusive to kidney. If you imagine going on bypass, your circulation has to be preserved to the vital organs. However, if you have an aortic clot clamp time that's quite long and then there's complications in the OR, then definitely your major organs take a hit by that kidney. So renal function might be compromised, and they already at not a good state to start off with. Maybe they're preceding pre-op stage. They have difficulty with their renal function. They could be premature, so their renal function is not great to start off with prematurity and then being newborn. They might be on nephrotoxic drugs such as antibiotics, like aminoglycosides for the newborn sepsis sort of management, and also the gut function might take a hit. Sometimes these patients coming back might have decreased perfusion with the gut, which might lead to complications such as necrotizing enterocolitis. And also in terms of the liver function might also take a hit because then you see the coagulopathy post-op. So you can see this inflammation response while going to a bypass has serious consequence post-op and leads to medications to manage the multiple, potential actual complications. So these physiological change post-op stemming from perioperatively inside the OR what's happened will peak around 12 to 18 hours. And we used to call it, when I first started, like, quote unquote, the witching hours, where people actually, they come back in the midday or later in the afternoon. Think about 12 to 18 hours later. That's when you're short staffed, it's nights, the amount of support might be relatively fewer than daytime. And they used to come back with closed sternum, closed skin, closed everything. And you can imagine just around the early morning hours, that's when they start call the cardiovascular surgeon coming, start opening. And it's not a great setup because it's very complicated, very high risk for the patient. So I do see practice change now. We if there's high risk patients, major post-op swelling and inflammation expected, they'll come back with the open sternum, closed skin, or open skin, open sternum, depends on the surgeon's assessment of these patients. So if they do have an open sternum, then that leads to another medical potential problem that as pharmacists we need to deal with, which is the antibiotic prophylaxis. So you can see that from pre-op, adding the Legos, and then the perioperative adding another set of Legos in terms of complications. So you're already coming in with a patient that's have a lot of Legos. The Legos are the medical problems that we need to address with medications in mind as the pharmacist. Okay, so then more to come. So now that the patient is in front of you in a unit, then you have to optimize contractility, blood pressure, and your real aim is to maintain perfusion so that you have adequate oxygen delivered to your tissues and organs, especially vital organs, your brain, your liver, your lungs, your heart, your kidneys, like major organs need to be perfused so that the body is sustained. So lots and lots of monitoring. I'm not going to bother you with lots and lots of what's there. There's mixed venous, arterial blood gases, lactate, and mean arterial blood pressure, your CVP, you name it, probably the course would have told you that already. What we really focus is what we call low cardiac output syndrome. You mentioned that, I mentioned 12 to 18 hours. That's when sort of the nadir, or maybe the lowest point where you really have to pay attention for the patient's clinical status. It might deteriorate. It could be around the time that they might have a tamponade, they might have sort of a continuous shock, they might need some steroid supplement, but perhaps not recognized post-op. They might need some boost for vasopressin because of relatively deficiency of vasopressin hormone in the body, and they start to be refractory to your epinephrine, and you need to add, norepinephrine, vasopressin, phentolamine. So polypharmacy approach might be needed at that point. Now, Miranol is a mainstay as well, so I'll go through that later. So the undying principles is, as you know, cardiac output is heart rate and stroke volume. And the stroke volume is the effective ventricular emptying in systole. So it depends on preload, contractility, afterload, and the heart rate all together in terms of, overall putting in the cardiac output. So all these medications, they are not new drug actually. They're pretty old drug, but it's very effective. It's a very pharmacological and receptor-based sort of, analyzing how they work. Okay, so catecholamines, we have on axis, depends on your center, dopamine, dobutamine, norepinephrine, epinephrine. I have to say that dobutamine, we haven't used it for eons, and usually it's for exercise testing, and we don't have that, in an acute setting, it doesn't have its place per se. Dopamine used to be around, and then we used to call it dopride, dopamine nitroprusside used to be mainstay almost like 25 years ago when I first started here. And as we have Emranol, which then associated with platelets issue, then the sort of a Me Too, better improved version of Emranol, Miranol, as it becomes a mainstay, dopamine and nitroprusside has sort of like, recede to the background. Also, we have some research done at the center and publication that dopamine might be arrhythmogenic. So you don't want that lined up in your post-op patients. So we tend to use epinephrine, norepinephrine, and the mainstay coming back from OR, everybody most likely will be on Miranol to have a sort of contractility supporter of medication. So Miranol is on top, and then you might have to add in epinephrine lowest dose to titrate up, and then norepinephrine if you need it, and then go on to with vasopressin and steroid supplement if you need it. Along the way, you'll have to maximize the calcium, especially if ionized calcium level is low, you need to optimize that through calcium supplement. Digoxin, we don't use it that much, except like I said, if you get into antiarrhythmias, then you might be on amiodarone or digoxin in terms of rate control, or esmolol, etc., etc. So that's another class of antiarrhythmics in case you need it. So what about catecholamines? We get it from endogenous, your own body, but probably post-op, you need some exogenous additional medication help. It regulates vascular and bronchiolar smooth muscle and really drives the myocardial contractility. So it mediates through the receptors mentioned here, sympathetic of the autonomic nervous system. And so it really affects a broad spectrum. It's your fight and or flight type of medications. So really the aim is to really work at the heart and also vasculature to maintain systemic vascular resistance. So you sort of help with the blood pressure. So in terms of postsynaptic, you have beta-1 receptors. Remember, my way of remembering is beta-1, you have one heart, so beta-1 is where those receptors are residing in your heart. Increased heart rate, chronotropic. Increased contraction, inotropic. Alpha-1 receptors works through a different mechanism. Again, it increased heart rate and it increased force of contraction. So these catecholamines work through beta-1 and alpha-1. Now, presynaptic is alpha-2 as a negative feedback through norepinephrine. So I don't expect you to remember all these receptors and how it works and where it works. Know that it's very heart and vessel specific. Okay, now in the vessels though, you do have alpha-1 and alpha-2 receptors, and if you act on those, it's vasoconstriction. If you act on the beta-2 receptors in the postsynaptic vasculature system, then vasodilation. So it's very complex sort of interplay between these receptors. Okay, so the bottom line is that along the way, there's also dopamine receptors along the way, especially in the renal system as well. So in a CCCU patients, your derangement from the operation, the bypass machine, it leads to resistance of these inotropes. Okay, so some of these norepinephrine, epinephrine, as you go up in terms of dose, you might find that the receptors are saturated, or that they might actually upregulate the body, sort of produce all these extra receptors. So you actually need more and more dose to titrate to response. At some point, you worry though, because are you over treating and overly clamming up your systemic vascular resistance? It's like a water pipe, nothing goes through. If nothing goes through, that's not a good idea, because in the quest of boosting your blood pressure, you have a very, very poor blood flow delivering oxygen or lack of oxygen by then, to your vital organs. So it's a fine balance. And that's why you see the interplay with, the clinicians playing with epinephrine, norepinephrine, depends on the patient response based on your lab parameters and your sort of your vitals and your monitoring lines at the bedside. So what do you do if you have variable response and then you sort of like continuous infusion, you have all these multiple sort of fine titration medications? So what you will need to do is, by the time that you're escalating doses, you might remind yourself that this patient might be steroid deficient, maybe vasopressin deficient. So that's when they actually see escalating. It's sort of refractory for the responses, or they respond initially to epi, then no epi, but now they don't respond as much, and then you see the dose driving up, and you worry about sort of too much clamp from the norepi. So that's when you actually add hydrocortisone for your steroid, which I'll talk about later, as well as vasopressin, just so that you have polypharmacy working on different receptors to make sure that you support the patient during this low cardiac output syndrome phase. Okay. Okay, dopamine, I don't want to spend too much on it because we don't really use the dopamine as much anymore. So it's just for your reference. Arrhythmogenic, so we sort of shy away from it now. Same for dopamine. Now, what about phenylephrine? Say you try everything. You throw in your epinephrine, then you add norepinephrine, a bit refractory. So I'm already on hydrocortisone. Then I add vasopressin. By then, what else have you not tried? And if your systematic or your systemic vascular resistance is still low and you need to boost it up, you can add phenylephrine. And that's a very, very target focused alpha 1 agonist in vascular system. It increases your SVR quite fast. And, I personally receive it doing, in my past when I was delivering my first baby. That's a personal story. I was losing my blood pressure, and I think I was giving myself too much fentanyl for my PCA. And as they sort of, operate, and then I start seeing my visual field like closing in, and being a true pharmacist and still awake, I told the anesthetist, can you please give me phenylephrine? She said, well, the blood pressure it's okay. I said, no, I'm feeling it. And then the minute I said that, and then the monitor is actually delayed compared to what the patient feel or I feel, then he gave me the phenylephrine, and right away my visual field normal. I was actually quite feisty, and I have my blood pressure back. So it's funny when I read about pharmacology, but it's funny when you feel it as a patient. So I know phenylephrine is very fast. It sort of boosts my blood pressure right away. So increase SVR. There's no beta effect, and the range is really wide. I mean, obviously you don't give a 0.5. In fact, we probably start at 0.01, then titrate up according to blood pressure parameters. And obviously you want to make sure that it's not clamping up so much that you don't have perfusion. Now, one thing is caution is that I showed you the infusion calculator last week with the resuscitation. I think that keep in mind that phenylephrine comes in a formulation that's very small dose. I would say small volume but high concentration. So to mix a concentration that allow you to titrate and suitable for the small amount needed for pediatrics, you actually need to do two-step dilution. So if you're interested, I think Cecily can share that. I don't want to just put in a slide like that because more related to administration. But I think that lies the difficulty that although pharmacology-wise, the drug-wise, we have everything here that's needed, but when it comes to infusing a small amount concentration or diluted concentration to allow this titration and deliver this tiny little doses of infusion for the patients, you might need to be sort of creative with a two-step dilution to get what you can do to draw up adequate amount, but such a small amount to mix the infusion for pediatrics. So that's something that's not only exclusive to phenylephrine, but for phenylephrine, we do have do a double dilution. Same thing for vasopressin. It comes in such a small dose, but it's still too concentrated for pediatrics. So when you mix a vasopressin infusion, you might have to do a double dilution step. Okay, so epinephrine, our friend, it's everywhere from resuscitation to here to even for asthma management when you're inhaling epinephrine. So anyhow, so it's beta-1 agonist. It's dose-related effects on other alpha and beta receptors. High dose alpha affects vasoconstriction, and it does increase conduction through the AV node and Purkinje fibers, increase SA node. So really, it is arrhythmogenic as you titrate up. So it's not something that's harmless, and it's not something that you can titrate response and go up and up. At some point, you're going to have to rely on polypharmacy using norepinephrine and other medications I mentioned earlier. Okay, so I mentioned pharmacological rationale already. The range is huge. You can range from 0.01 to 0.1, and in fact, on our PICU septic shock patient, you can go up to 1, although by then it's pretty serious. So you can imagine the safety hat when you put on as a pharmacist, for example. We always think about this 10-fold or 100-fold, 0.01 to 1 mics per kilo, that you have to be very careful in terms of ordering, especially with verbal order, especially with, oh, can you titrate up to 0.01 or 0.1? What if it's so noisy you can't hear it? So you need to really have a safety checkup for these drugs that have like a 100-fold dose range. Okay, all right. Now, I'm not sure if Cecilia want me to share this because it's a very localized method, but I put it here anyway. If you have any further question, you can ask Cecilia myself. So in our unit, for those patients that actually have certain criteria where the team felt a bit precarious, and until they can sort of connect with an ECMO bypass machine should they need it for heart support. During that time when during that really critical stage where it's deteriorating, it's not a cold blue resuscitation, yet, but they might need a little mini dose to tie them over until the fellows can connect and call in help, and it's like it's more efficient than trying to set up a bolus from the pump. You can actually have this 1 microgram per kilo dose. It is 1 in 100,000, so note the strength is 10 micrograms per mil, and this is the instruction in the slide how to mix it. I don't want to belabor the point. I think that this is just something that in case you have a pump limitations, in case that you need time to set up the ECMO machine, this is something to bridge, with the fellow's attention and then waiting for things to get set up to sort of, avoid the patient going to full cold, but helping them to transition to the next step in terms of ECMO support. Okay, so that's the pre-arrest here. So those are the criteria for central ventricular palliation, those with cardiomyopathy, unstable coronary perfusion, prior to intubation in patients in shock, heart failure, myocarditis, balloon, atrial septostomy, those on ECMO or getting into ECMO, those already managed with epi in case they need that extra boost. So those are the conditions that we as a group in our unit developed many years ago under our former chief Peter Lawson, and sort of he worked with us with this setup, and Steve as well, Stephen, our current interim chief, Stephen Swartz, to sort of set up for a patient to support them. Now, what about norepinephrine? It's usually the second in line, not in terms of inferiority by drugs. It's just that usually if epinephrine doesn't work as well as we want it to, we will add norepinephrine. So primary use was alpha effects, so really increased systemic vascular resistance, vasoconstriction. Hopefully no change, but it might decrease cardiac output because like I said, it's like a tube, a pipe. If we squeeze it so much, your cardiac output's gonna go down, and it's like working very hard by then, that poor heart, to pump against a higher SVR. So is it the last resort? Is it polypharmacy? You can't tell. You really have to play with that titration with different drugs. It's almost like a fine art. The magic combination might come and go and might change as the patient, stay in the ICU post-op changes. So again, this is 0.01 to 0.1. It's quite potent, so we usually don't even go up to 1. So again, it is very focused on the increase SVR here. What about isoproterenol? Maybe I shouldn't even mention that because right now there's a big back order, so we're saving it. But anyhow, it doesn't really have a big stay in post-op management for our routine post-op cardiac. However, in heart transplant population post-transplant, it does regulate the heart rate because the denervated heart hasn't had time to sort of acclimatize in the new body. So we use the isoproterenol post-op heart transplant for a few days until the heart transplant feels that the patient's heart rate is stabilized and doesn't need that. Okay, so I just want to mention that. So the concerns, like I said, is you do need adjunctive therapy because it can cause tachyphylaxis. Sorry, I can't hear. Cecilia? I heard some interference, but anyway, I'll keep going.
Yeah.
Side effects are listed here, and you do have the expense of working harder to pump it. It's arrhythmogenic, so you need other things to help. There's some potential complications listed in the last bullet point here. So that's when Mirinone comes in. Amrinone, I won't mention it. It's sort of a former generation with some platelets issues. So now for the past 10 years, if not more, we've been using Mirinone. It's a direct positive inotrope effect. It doesn't work the same way as the epinephrine or isoprel. It inhibits the cyclic AMP phosphodiesterase in the cardiac and vascular muscles, so it helps them to relax. If you relax, you can pump better. It also has some inotropic effects to make the muscle contract better and stronger. And it's sort of helped by inhibiting the enzyme that breaks down the CAMP, the battery, the cyclic AMP. So if you don't get battery breakdown, you have more battery per se to help the heart pump. It enhances calcium reuptake, cause after contractility relax, because without relaxation, you can't really contract because then that's not effective. So you need effective contraction and relaxation. So we call it lusitropy. So it's really people say this is really a nice, magic, easygoing drug that helps so that you can see a lot of our patients, every single one of them come back on Mirinone. Most, I would say 90%, if not more. So it does vasodilate. So it's sort of a double-edged sword. So if you have a low cardiac output syndrome sort of patient, sort of, evolving low cardiac output over the next, 12 to 18 hours post-admission, the Mirinol is good and it helps. But if you have to increase or they're running a higher dose, and if they have some perfusion issue causing the renal function, deterioration or impaired renal function, Mirinol is cleared by kidneys. That means if your post-op low cardiac output cause your renal to not work, then your Mirinol, even though on a medium dose, could actually be per se the patient seeing a higher dose. So what happened? Well, it does have contractility and relax the vessel, but it can also cause hypotension. So is it the hypotension caused by the Mirinol, or is it the hypotension caused by your low cardiac output syndrome? So it's kind of hard to detect, and because it's tricky, it is a longer half-life. That means that you might need some time to really find out if I decrease Mirinol, is it worse for the patient? That means they need it. If I reduce the Mirinol, the hypotension resolve, that means they don't need it, maybe too much. But because long half-life, you can't know right away. You might have to wait a few hours before you drop the dose, like, oh, you need more? Or no, you don't need more. So that's the tricky part. In the meantime, while you're finding out what's going on, you might have to use the faster acting, shorter acting, faster response epinephrine or norepinephrine to help you fine titrate to find out, is it the Mirinol or is it not? So that's the trick that we learn over the years. So that's why you're not going to be finding it published somewhere in the RCT. But I just want to share our experience with using Mirinol. I do have a special place with both Emerald and Mirinol because I think that I helped to launch it and it's helped to monitor its use. Emerald, we were a bit scared with the platelets issues, and we did review, and there was some instance of Emerald-induced coagulopathy that you can't really tell whether it's Emerald or because of disease state. So when we brought on Mirinol many years ago, I think that we find sort of a good balanced drug for these patients. Mentioned this already, very, very rare thrombocytopenia. We can't tell whether it's post-op or Mirinol's likely not. Fairly fast, but like I said, the duration of effects once you stop is about 3 to 6 hours. So fairly long half-life. At least the pharmacodynamic effects life is longer than minutes. It's hours. Okay, the dose range we can go up to 1, although we now max at 0.75. So this is a bit dated, but really we start with 0.25, then 0.5, then 0.75 max mics per kilo per minute. There's a very famous landmark trial called Primacorp. It's really a fine study, and they really set the mainstay of using Mirinone. It's a bit dated, but it's a good drug. So I think we still follow that trial studies. Stability data greater than 24 hours. So what we help the nurses are, because everybody's on it, pharmacy actually make a batch, and then the nurse doesn't have to make it a bedside. They can grab and go of the prepared syringes by pharmacy in our Omnicell. Okay, and it's fairly friendly in terms of veins, PIV or CVL. So that's one drug that you can be fairly compatible and run a PIV as well as CVL. The only bad thing about it, and it's not bad, is that it's not compatible with furosemide. And you know that these patients are often on both, so we have to have enough access to sort of separate the two. They're good drugs, but they're not friends, so we don't want them together. Okay, so I think that those are just extra stuff. And what about vasopressin? So we talk about mainstay, Mirinone, everybody come back on it from post-op. And then into the low cardiac output phase, they might still need a bit of epinephrine, then maybe norepinephrine, then maybe steroid, hydrocortisone to supplement this relative steroid deficiency, and then the vasopressin if still needed. So what about vasopressin then? Right now, we don't use it that often. We also have a back order with unknown return date, hopefully the end of November, if not December, but we don't know yet. So really, we're conserving for those that really need it. It's an endogenous hormone, just like epinephrine. Okay, and it's synthesized in the hypothalamus, and it's usually present. It works through V1 receptors in vascular smooth muscle, cause vasoconstriction. And one have to be careful. When I first start using it in a unit with a team, we don't have a good feel of the dosing. And often it's not as if you have an RCT telling you what dose to use in your ICU patients with pediatrics. So we sort of borrow a page from how they use it in adults, post-op and sort of septic patients and other type of adult patients and extrapolate. And we did go high in some cases because we're learning. And we did find that it vasoconstricts so much that it constricts your GI vessels, vasculature. And that's not a good thing. You don't want a neck, you don't want GI bleed. So I think we're learning that, right? And it's not GI bleed, sorry, it's a vasoconstriction, but you don't want sort of an enterocolitis or necrosis going with your already underperfused gut. It does decrease coronary blood flow if you use too high a dose, so we're very careful, and I'll show you the dose later. V2 receptors for renal is the antidiuretic hormone, as you might know. And so we mainly use it in the post-op cardiac for V1 receptors effects. So those are listed here, but for us, it's like septic shock and really the bullet 2 of bullet 3 here in the slides. Vasodilatory shock after cardiac surgery is what we use for. Look at the dose, 0.001. You know, that's our starting dose, and they don't really use it beyond 0.003 because we really know that when we get up to 0.02, it might have a lot of side effects of vasoconstriction. It's very potent. If you use it for septic shock, it's a little bit different. Those are in PICU, bigger teenager, we may actually use the adult dose and not maxed out. You can easily see that if you just go by per kilo, if you have big teenager or high dose, you might actually exceed the usual adult dose. For our purposes, I would say that vasodilatory shock after cardiac surgery, little dose 0.0001, and that's what we use for. Okay, so what about, we all talk about vasoconstrictors or vasopressors. When would you need vasodilators? I mean, a lot of times you worry about hypotension. However, we do have patients coming back with pulmonary hypertensive crisis, or at the very least pulmonary hypertension. It could be primary, secondary. They might be on nitric oxide, but they might need also support of vasodilators in terms of medications if they're on bypass, if they have a pulmonary hypertension issue. So phenoxybenzamine, we don't have that anymore, so we use phentolamine. Esmolol, labetalol might be useful agents. Vascular smooth muscle action medications are nitroprusside, nitroglycerin. I mentioned NO, which is not medication, but we do have it. It's super expensive, and we have a stewardship program in our unit to monitor the use and the need of NO. And we used to use L-arginine. Now we use sildenafil, and there's prostaglandin or epoprostenol as well. So we do have a sort of an expanded scope of medications to help vasodilate, especially with pulmonary hypertension issues. Nipride is listed here. I have to say that we don't use it as much. Okay, we do have the Miranol now, so we don't use dopamine nipride. But on occasion, when they're on ECMO and they have a lot of facial constrictions, they need a vasodilator, we might actually need this. Okay, it is not a harmless drug. It can result with long-term high dose, usually long-term and high dose, thiocyanate and cyanide toxicity. We don't have good assays in Canada to process the blood levels of these. So what we use is the methemoglobin as a surrogate marker. And usually they will monitor when patients are on NO anyway. Okay. Cyanide toxicities, I mentioned it here. I don't need you to sort of memorize it, but keep in mind high dose. And when you get into like 3 or 4 days, you really have to find something else to get it down. Okay, nitroglycerin, again, I don't use it as much compared to adult ICU. It's very coronary specific. Sometimes though, with coarctation repairs or other type of repairs where they have to sort of operate near or with the coronary arteries, the surgeon might request the use of nitroglycerin. Again, very, very rare use nowadays. Now, phentolamine, we do use this. It's incomplete compatible alpha receptor blocker. It basically relieve your vascular smooth muscle tone, so it's decreased peripheral vascular resistance. Particularly useful when they have these hypertension crises in the ECMO, when they bypass, so that they don't fight, all these machine support as well as the pulmonary hypertension kits. Okay. All right. Fast onset, and I have to be honest. Nobody knows the optimal dose. And it's titrated response. We'll start with 1, sometimes boluses. And I think we feel more comfortable now to going up to 6 and even 7 in titrated response. And because the peak effect's 2 minutes, fairly short acting, over the hour or two, you can quickly escalate it, the drug to optimize your response. So a lot of times we're limited by relative lack of evidence or dose range for these drugs, because these are all drugs used for different purposes. We just adapt them how to use it to manage post-op cardiac based on pharmacology, if you think about it. Okay. Now, so despite everything that you try now, and then you think that it's still refractory, you might need corticosteroid. Reduce inotrope requirements. Now, in the neonates especially. Now, pre-op, we do give the neonates who are going for bypass, going for hypothermia, to minimize that inflammatory response I talked earlier by giving them 2 doses of methylprednisolone, in terms of pre-op. There's no rhyme or reason why a particular steroid was chosen. Some centers use hydrocortisone, some centers use methylprednisolone. And in terms of dosing as well, it's sort of like empiric standard of care. And it does, by pharmacology, makes sense to give it, but whether it decreased it caused immunosuppression, other type of side effects, it's hard to monitor in these complex patients. Now, post-op though, we tend to use the hydrocortisone shorter acting, 2 per kilo load followed by 1 per kilo Q6. We reassess duration. As soon as you're able to wean off the vasopressin, your norepi and epi now in a low dose, you probably can step down. You don't need a wean hydrocortisone because it's short duration. However, rather than wean, it's more like stretching the interval to see if they still need it in terms of inotropic support. So I don't like the term, oh, you need to wean hydrocortisone or a patient is on a wean. No, they're not on a wean for HPA axis suppression. They're not on a wean because they've been on it for a long time. No, I think it's a stepping down to sort of test the patient. Are you ready? Are you ready to get off the steroid now that you're on a lower inotropic support? So I think we stretch to like Q8, Q12, then Q24 and stop. Okay. And usually once they sort of come down inotropes requirement, that's when we actually recommend, start backing off the steroid. Reason is it is not benign drug, as you know, it's fluid retention, immunosuppression. These patients are at risk for infection already. So the shorter steroid exposure, the better. Sometimes if they fail to step down, then you might have to consult endocrine, like is there underlying, steroid deficiency, some underlying metabolic endocrine issues. So that's the sort of the red flags if they fail to wean, quote unquote, or step down hydrocortisone. Okay, Increases mean and systolic blood pressures, reduce pulse rate, allow weaning or backing down. Again, maybe on a higher dose of norepinephrine and then perfusion is taking a hit, the kidney is not doing well. If the steroids help you to reduce those doses, then might restore perfusion to these vital organs, which in turn affect your clearance of the drugs. Beta blockers, Esmolol, is fast on, fast off. That's our sort of to go to IV Esmolol. Some centers using labetalol, but we just use Esmolol. It's just what we're familiar with. Okay, so when do we use it? You usually use in the pre and post-op coarctation. So obviously you don't want hypertension in these patients, and we usually have a lower blood pressure target parameters post-op dictated by the surgeon and the cardiac intensivist. And so we tend to use as infusion because in case it's too much, it's hypotension, dropping your heart rate, you can stop it, right? Okay, libido, I'm not gonna go through it. That's more usually is what we go for. Uh, Now, it may worsen heart failure, hyperreactive airway disease. We talked about beta blockers before, but really, it's a good mainstay because it's so short acting. Just a sort of a caveat: we don't usually load unless we really want to, because if you load, what if it drop your blood pressure precipitously? That's not good. Whereas if you titrate up, you probably have time to back off because short half life for these patients. Okay. Atropine, I think that we mentioned in resuscitation lectures, but anyway, it's listed here. We don't use it as much. Um, okay. Counter bicarb. Now this is get to resuscitation. It's really buffer for metabolic acidosis. The list is here, but for neonates, if we try to use the 4.2% in case there's some reports, very old literature about increased risk of intraventricular bleed, head bleed. So we try to sort of nowadays though with the pump management, with the pre-op and perioperative care, we don't have to use sodium bicarb, even boluses as frequently. It's really the team does a good job managing these patients. So drawing to the end part of the lectures is there's a lot of complications. If I keep going on each complication as a lecture in itself, I briefly touch upon pulmonary hypertension with the NO, and then using in terms of phentolamine, sometimes nitroprusside, nitroglycerin in case they need it for pulmonary hypertension vasodilatation, and later on once they're ready for enteral, you can use enteral sildenafil. Although we also have IV sildenafil, it's constantly on back order. So we try our best to deliver medications in spite of medication drug shortage. Bleeding, you might have to use tranexamic acid along with some factors, and blood transfusion. Thrombosis is a big topic. It's anticoagulation, and we have coverage of that topic. But really, the heparin versus bleeding, it's a tricky drug to titrate with heparin. And of course, if you come back with a ventricular assistance device, if it's a Berlin heart, we'll be using the bivalirudin, a new agent compared to the heparin, more like traditional agent. Hypoglycemia, I believe that in next term, you'll have a talk with me with management of hypoglycemia. Pain and sedation, you just have a talk from Azi and more to come. Muscle relaxation, those are important. If you're such a complicated patient, you don't want to stress the heart out or the patient out, then a short duration, they might maintain muscle relaxation while they stabilize the patient. But as soon as they can, they're going to lift muscle paralysis because there's side effects from muscle paralysis itself. Fluid overload, which is diuretics, which is quite a big topic. So it depends on time whether you want me to have extra information with my next lecture about fluid overload management. And corresponding electrolyte disturbance and replacement. Just like I mentioned about corticosteroid with a relative corticosteroid sort of like a deficiency, these patients might have a sick thyroid syndrome with their, especially if they chronic, longish term, like a few days into the state, into a weeks, they might need some thyroid supplement. And then at that point, you definitely need to involve endocrine because like steroid requirements, thyroxine requirements, they might have a syndrome with low calcium with the George. All these different syndromes might require special attention with consult teams. And along the way, I mentioned about open sternum. We are usually on prophylaxis of antibiotics. Cefazolin has done a great job all these years with good wound care by the nursing and dressing changes. we do have a relatively low touch with, low skin infection or wound infection. Occasionally, though, with long stay complicated patients, it could be evolving to, nasty antimicrobial resistant organism wound infection on the chest or even fungus. But that's quite rare and does usually have other risk factors. So the sooner we optimize, avoid steroid or get off the steroid, the sooner we get the patient in good state, then hopefully we minimize sepsis or nosocomial or hospital-acquired infections. Having said that, cefazolin is a routine prophylaxis. If they do come back from the OR of open sternum, then we add aminoglycoside for additive sort of antimicrobial sort of prophylaxis. And although people worry about nephrotoxicity, with optimized dosing and level management or therapeutic drug monitoring, TDM, we call it by the pharmacist, is a good drug to use. And so we do have that regimen standardized in our formulary and guidelines. And of course, if they start having some septic syndrome, we will broaden it according to our empiric choices. Often we'll have Vanco in the mix because line access, gram-positive, screen fluoride wound, they will be empiric Vanco with other broad spectrum gram-negative coverage. And if needed, if it's really escalating, we might even need antifungal treatment for those patients. And by then, we usually involve the ID team if needed. Um, uh, Once all these complications sort of well managed and the patient stable, then what our job would be and would be opioids and sedatives weaning. I think as he touched on the pain and sedation, but we really have a good plan because a lot of these patients will be on a high opioid and sedative requirements, often would be dexmedetomidine transitioning to clonidine. Then you have your morphine from IV to enteral. Then they might be on a benzodiazepines to diazepam, oral wean. So these patients could be on a triple wean. So how do you manage them up on ward and transitional patients to the, even outpatient to manage? Hopefully not triple weans by then, maybe just one drug wean by the time we get to that stage. We also help to make sure that where we can, we give enteral diuretics, enteral medications, making sure that we work with dietitians about the GI medication in terms of like reflux management, anti-reflux medications. So those are in a nutshell. I mean, I don't want to spend like, a lot of the whole bulk lecture on all these complications. I think that depending on the availability of time in later in the course, I can certainly come back when I talk to you about hypoglycemia. Maybe if needed, I can include one or two of the key complications and talk about medications management. So with that, I think that's an overview. Let's see if there's anything else. Oh, I did mention some extra stuff here. So you can take a look because I have insulin lectures later on. So I'm going to not do that. Changing all these medications. Now, this is standard concentration card. I owe Cecilia and the whole unit a new and updated version. So if you have your practice center, this is quite a handy chart. And it evolved with a paper pocket card, laminated, different colors, different years. And since we implement CPOE with our Epic system, it's built in the Epic system, it's built in our Pump library. As well, we have an electronic infusion calculator, which will still require updating. I work on the resuscitation calculator now. My next step is the infusion calculator. It might be a handy card, especially if you're doing bridging calls and external people don't have your access to electronic tools. You might just use, for example, alprostadil. If it's less than 15 kilo, I have greater than 15 kilo because it's used for another indication for liver transplant. But for our purpose, less than 15 kilo, zero point zero 0.01 mics per kilo per minute, you read across, and that's the standard concentration if you use a, say, a Laris pump or other pump that use standard concentration, and the rate would be 0.3 times the weight of the child. Fairly straightforward. Simple is good, especially in these stressful scenarios where you have to mix up the syringes or communicate what to mix for a bridging call. This is good. I mean, they might not have access to this card or electronic infusion calculator, but that gets you when you want to, especially if you look at epinephrine. It tells you you must run it in central line if you can. What dose do you want to start? Likely 0.01. Then depends on the weight. This is our standard concentration. Now, if you go and escalate your dose, of course, you can jump to the next concentration like 0.25, zero point 0.5. People wonder, why do I standardize to 50 mil? It is what it is. Our unit are used to use 50 mil syringe because it gives you the flexibility of going up the rate and one syringe lasts 24 hours and minimize drug wastage. And what about concentration? Well, it depends on the dose. If with epinephrine, anywhere from 0.01 to 0.1, you definitely need different concentrations. Otherwise, you'll be running a very diluted concentration at a high dose for a high rate, then that might actually push your patient over with fluid restriction to fluid overload. So this is a fairly practical card. I don't mind sharing, so include in the slides tiny font. But if you needed to, I do aim to revise my card in the new year resolution of 2021, so I can share that as well, because hopefully you'll still be in the course and then I can share it. Let's see what else is there. Resources I listed there, references, and thank you. So any questions at this point? Any? Don't know if they
It looks like none at this point.
Okay, all right, good. So I promise, and then next time I see you in the new year, I think it's somewhere in April, then we'll talk about the sugar management, any additional topics you want through Cecilia, and hopefully I really hope that card will be revised and I can share then. Okay?
Thank you, Winnie. That was a great talk. Just
Thank you.
combining all the drugs, the vasoactives, and also touching on some of the drugs that we've talked about this afternoon. So hopefully everyone enjoyed this day. Using a lot of case studies, I think, was probably really helpful in helping people to understand how we use them and how we wean them. So hoping everyone's a very nice weekend, and we'll see you next Friday. Any last comments from anyone?